Hi, and welcome to the last part of the introduction for the Mulligan Concept course you are about to attend. In this part, I would like to focus on the guidelines of MWM application. One should know CROCS before starting treating with MWM. It is an acronym that reflects the way we think in the Mulligan Concept. The first C stands for contraindication. One should first exclude red flags and apply manual therapy only if no contraindication exists. This was previously shown in the flowchart described in the first part of the introduction. Go back to it if you need a reminder. For example, post-trauma, we should consider the need for imaging prior to applying a manual external force. As a rule of thumb, MWM should not be used when manual therapy is contraindicated. Sometimes we will need to refer the patient to the medical doctor if we suspect such a case. As an example, we might see a patient complaining of neck pain with limitation of rotation and signs in his story of an active autoimmune problem, as rheumatoid or psoriatic arthritis. Another commonly missed presentation is the male patient with posterior pelvic pain and a story making us suspect of the existence of spondylitic arthritis. These are commonly missed. R stands for repetition. When first applying MWM, we use it as part of our assessment. Our first goal is to assess patient response, the pill effect, as we never use MWM on a non-responder. We just do a few repetitions, looking for a direction and force that will allow the patient to execute his symptomatic movement asymptomatically. This might take anything between 1 to 5 or 6 repetitions, depending on patient clinical presentation. In most research investigating the efficacy of MWM, 3 sets of 10 repetitions were used in the peripheral joint. This number was taken so all patients will get an equal load intervention. It's perhaps a good number for the average patient. But as I said previously, our patients are never the average. They are all special and we treat them as so. N equals 1 with an exclamation mark. In the clinic, the number of repetitions and sets depend on patient load tolerance and response. In high tolerance patient, we can continue till movement is significantly improved or pain-free. On the other hand, in patient with low tolerance, we might stop once we get a response good enough to warrant the treatment significant. In the spine, mainly the lumbar spine, Brian suggested to use cautious on the first treatment. There is a strong tendency when treating the lumbar spine and neural tissue to have a late-in response. To avoid that, Brian proposed what he called the rule of 3. Don't apply more than 3 effective repetitions on the first treatment. Our goal on the first session is only to test response. This is relevant also in treating in some patients with upper cervical spine-related symptoms as well. Although in her research on cervicogenic dizziness, Dr. Sue Reed applied 6 repetitions on the first appointment with no adverse reaction recorded. In further sessions, we should match repetitions to patient clinical presentation. So for example, when the patient is acute, intuitively, you might do less repetitions. But what about the chronic, or better said, persistent painful patient? Is there a difference depending on the response we achieve in these type of people? If a chronic patient changes dramatically during first treatment, compared with a patient gradually changing. Should we adjust the number of repetition depending on the level of change? Probably yes. Less for a fast change, more for a slow and steady change. We need to allow for functional adaptation to occur, especially in these patients. That's another aspect of a person-centered approach. So in summary, use your common sense when deciding on treatment goals and loads. Next in CROCS is overpressure. Overpressure is defined as the difference in range between active and passive range of motion. Brian Mulligan emphasizes the importance of overpressure for achieving a long-lasting effect. When considering overpressure, there are a couple of points that should be considered. First, who should provide the overpressure? The therapist or the patient? Asking the patient to apply the overpressure serves a few aspects. First, engaging the patient in treatment. Second, the patient can better feel the initiation of pain and load the system optimally, with better control over fear of movement. We should be aware to be cautious with some patients when applying overpressure, such as osteoporotic patients, especially in the thoracic spine. Other special case of osteoporosis will be discussed in the clinical part. In patients with hypermobility in general, and pregnant women specifically, although overpressure is not contraindicated, we should use it with sensitivity and let the patient understand she or he should only apply some extra force and not maximal force. We already mentioned the importance of clear communication when applying MWM, explaining how patients should move, when to stop, how and when to self-treat, what to expect, etc. Communication is an essential part of creating a therapeutic alliance in general and specifically in the Mulligan concept, since the importance of patients' engagement in treatment is essential. As physiotherapists, our knowledge of pathology, physiology, biomechanics, etc. should be taken into consideration in every treatment we provide, including the Mulligan concept. One should use all his knowledge to provide adequate, safe, and optimal treatment and set realistic goals and expectations. The last S of CROCS represents several guidelines. Always use your common sense. We say that even when guidelines are followed, one should use his logic when providing treatment. Common sense will guide us to how much and when to use treatment. When applying MWM, one should keep a sustained constant force throughout the patient movement, following the joint surface direction. The sustainability of the direction and force is perhaps an important aspect of the patient's central nervous system, CNS, to adapt. Be sensitive to any verbal or non-verbal response. If the patient seems uncomfortable with our touch, we should adjust it before asking him to move. And last, aim at improving your skill. It doesn't take years to learn how to apply MWM, but like any other art and proficiency, to master it takes some effort. Repeating the technique as well as the clinical reasoning on as many patients and occasions will most likely affect your skill and treatment success. Let's summarize the guidelines of treatment with MWM and SNAG. As mentioned, when introducing pill, MWM should be pain-free, and our initial aim is to find the optimal direction and force to get a responder. Once achieved, this has a diagnostic value as well as a therapeutic one, It's not about diagnosing a tissue pathology, but as mentioned, the reset point, the level or a joint that when force is applied over it, allows the system to load symptom-free. The importance of repetition was already discussed. These should be followed by self-treatment or by moving while being taped. I will elaborate about self-treatment and taping soon. Mobilization is applied using a manual force or treatment belt. In both cases, the force applied should be the minimal one to provide a pain-free movement. The use of a belt is not done to gain more force, but rather to provide a more sustainable force throughout time and movement. To be effective, the external force of MWM is applied initially in the loose pack position and when the joint is unloaded. Brian Mulligan suggested that overpressure has an important role in providing a long-lasting effect and should be applied from the first repetition if this is pain-free. Once more, it is important to stress that MWM are patient-specific. So if you have a reason to think that patient tolerance to overpressure is questionable, you might decide to execute the first few repetitions without overpressure, and then, after reassessing, do the second set with overpressure at the end of range. Once more, it has to be pain-free range of motion. The mobilization force should be kept sustained till the patient returns to the neutral position to allow for optimal adaptation. Looking at the movement component of MWM, as mentioned, it should be meaningful to the patient, preferably active, but can be done passively or assisted active movement as well. If a muscle contraction is provoking the patient's symptoms, it can be used. We should try to make the patient movement as meaningful, contextual, and functional as possible. Choosing a weight-bearing or non-weight-bearing position as relevant and tolerable, and try to get the maximal pain-free range of motion. We should remember that MWM most often are not a standalone technique, and they should be integrated with other relevant forms of physiotherapy as needed. The first step in using MWM is to decide on the type of MWM. This depends on the type of joint we aim to mobilize or aim to create an effect on. The main MWMs are glides in all directions and rotation. In hinge-type joint, as the wrist, elbow, knee, and others, we first apply external force in 90 degrees to the physiological direction of movement, i.e., lateral or medial glide. If no change is achieved, we can try to mobilize into rotation. If a partial effect is achieved with glide and rotation, they could be combined by either combining the manual forces or applying tape in one direction and manual forces in the other. The knee, actually, is a special one. We use rotation before we use glide in most cases. With complex joint as the carpal and tarsal bones, we randomly choose an upward and downward direction. This could be adjusted in any direction if needed. Long bones are defined in the Mulligan Concept as bones that are connected to each other at two joints, proximal and distal. We can either mobilize the proximal one or the distal one and adjust inclination by moving up or down along the bones. Needless to say that mobilizing both the proximal and distal joints simultaneously is sometimes beneficial, especially in the radioulnar and tibiofibular joints. In all cases, one should follow the movement of the moving bone as relevant. This has been suggested by Keltenborn to keep the mobilization force parallel to the joint plane. It is important to remind at this point that the objective of MWM is not to restore normal joint biomechanic, but to restore outcome, to restore pain-free, symptomatic-free range of motion and function. Another important factor in treatment is choosing the direction of patient physiological movement. As stated previously, this movement should be meaningful and contextual to patient need and expectations. We should always start toward the physiological direction most relevant to the patient dysfunction. But if we fail to get a positive response, we can try asking the patient to move the other way. In other words, flexion instead of extension, extension instead of flexion. This is applicable only if both movement directions are limited or symptomatic. In some cases, it's surprising for both us and the patient that improvement of one direction leads to improvement of the other. But please don't show the patient you are surprised. The next step after deciding about the type of MWM is choosing the level of snag and direction of MWM. Looking at peripheral joints, we should start by applying an MWM in a primary direction guided by research or our clinical experience. That will be direction number 1. We do that in the joint under the area of symptoms or the one we suspect is provoking patient's dysfunction. If the patient reports that the movement is pain-free while MWM is applied, we continue with repetitions as previously discussed. If patient response to the initial direction and force is with partial relief of symptoms, we should slightly adjust them. We can either adjust our force or force direction. When adjusting force, remember, it's not always the stronger the better. Use common sense and sensitivity. If adjusting force direction, do it subtly. This is number 2. If the new direction is providing a peel effect, we will continue with it. But if by changing the inclination in one way, patient's symptoms are getting worse, then we should move the inclination in the other way. That will be point number 3. If the patient response to direction number 1 is increasing of symptoms, we should reverse the direction of force to the opposite one. That will be arrow number 4. As we say, if worse, do the reverse. In some cases, no change is achieved when applying MWM, unfortunately. If such a response occurs, we should try to mobilize the joint in a different plane, so move from glide to rotation, for example, or move to an adjacent relevant joint. In the spine, it works in the same way. Initial level of snag is chosen depending on patient complaints. Arrow number 1. We start mobilizing on the level inside of symptoms. Change of snag inclination is made as mentioned previously if partial results are achieved, moving the force direction more or less cranially. That will be arrows number 2 and number 3. And instead of reversing the snag direction by pushing on the anterior aspect of the vertebra, which might tend to be uncomfortable to the patient if symptoms go worse, we just move a level down or up. When there is no change in symptoms in the initial application in the spine, a change of plane can be used by moving from a central snag to a unilateral or by applying a lateral snag. That will be arrow number 5A. Another option, 5B, is to respond when no change occurs, is to snag in a different relevant region. For example, moving from the upper to the lower cervical spine, or from the lumbar spine to the sacroiliac joint or hip. When we suspect that the reason for failure to achieve pain-free MWM is due to a patient's sensitivity, we might try using a foam to reduce local discomfort. This is why it's always important to ask if the patient is comfortable with our hands before we ask him to initiate movement. Let's have a look at relevant factors of treatment progression with the use of MWM. It's rather logical that if a patient complains of symptoms in a low level of tissue load, as in non-weight bearing, one should start treatment there and gradually increase to higher levels of loads as in partial and full weight bearing. This is normally how MWMs are progressed. But as you can notice, the arrows on the left flowchart have a bilateral direction. That has a meaning. It's not by chance. In some patients, adding some level of weight bearing improves response to MWM. Perhaps this is due to a different afferent input to the central nervous system facilitated by joint surfaces compression. Progression of treatment can be done with adding components as speed, resistance, movement complexity, and any other relevant contextual addition. When applying assessments and treatment with the Mulligan Concept, consider the patient sin, severity, irritability, and nature of his condition. For those not familiar, in short, severity is the level of patient pain, usually between 0 to 10. Irritability is comprised from how easy it is to provoke symptoms and how difficult or how long it takes to ease them. And the nature and the natural history and progression of the suspected complaint. Knowing this will direct your decision about the level of load exposure you can use and adapt it to the patient's symptom provocation. Using self-treatment is an important component of the Mulligan Concept, and using it properly is an art. I ask you to specifically use the phrase self-treatment and not exercise. Exercise are given to patients so they have something not to do. It's a joke, of course. But if someone gets his self-treatment, a way to take control over his symptoms, and he doesn't take it, communication with respect to the importance of it should be emphasized. With these patients, I usually focus on the beginning of the second treatment, on revising the self-treatment, and I make them do the self-treatment several times to empower them and demonstrate to them how effective they can be in treating themselves. Yes, we can sometimes tell the patient exactly how many repetitions and sets of self-treatment they should do. I call it turning active exercise to passive treatment, since it takes away patient's choice and control. It is better, in my opinion, to give the patient tools to understand when and how he should treat himself. Last point to consider before moving to look at how should we do it is when should we teach it. It is highly important to teach self-treatment as soon as you found an MWM that works. When the patient is still symptomatic, he should see that he is as effective as us in treating his own dysfunction. I always say to my patient, you see, you are as good as I am. That's empowering the patient and builds confidence and autonomy. Next is when. The patient needs to know how to apply self-treatment, when to apply it, when to do more or less, and when to stop. It is called active knowledge. Self-treatment, when you expect the symptoms to appear. For example, if you feel your back pain when you first load it in the morning or when standing from sitting, do a few sets of self-treatment before you do so. If you get your shoulder pain swimming, so do them as part of your warm-up and perhaps after your swimming session as a cool down. Before treating, assess. Do the comparable sign decided on or any other symptomatic movement. If no symptomatic, self-treatment is not needed. It's not indicated. Don't continue and assess again when you feel symptoms are coming back. If the comparable sign is symptomatic, do your self-treatment. Adjust direction and force to get the same results as you did in the clinic. Apply a few repetitions as you feel. Don't overdo. Remember, they should be pain-free. After the first set, reassess. No pain? Stop. No need to do another set. Still painful? Do another set and reassess again. Continue till pain-free or till symptoms plateau. Self-treatment is a powerful tool if used correctly. It's engaging the patient with treatment and giving him autonomy, power over his symptoms, and promoting self-efficacy. A great tool we have to control patients' symptoms is taping. It is an important component of the Mulligan Concept, and we use it as an extension of our hands. So try to imitate the same location, direction, and force as you did with your manual technique. If a patient complains of pain only when performing a specific task, as running, training, swimming, or any other, he should be taught to apply the tape only during the particular function. If a patient complains of symptoms throughout the day, then he is advised to apply the tape when he wakes up in the morning and removes before he goes to sleep. When complaining of night or AM pain, it is highly recommended to try and sleep with the tape on and see if it helps reducing or eliminating these symptoms. An example may be a patient with plantar fasciitis complaining mainly on pain when he first loads his foot when he wakes up in the morning and loads it. Apply the tape overnight and ask him to assess his AM pain. In the Mulligan Concept, we most commonly use rigid tape. If the patient needs the tape on for more than 2-3 hours, it is advised to use a hyperallergenic tape to avoid skin reaction, since the glue of the rigid tape contains materials that may cause an allergic reaction and skin irritation. With the under tape, it is still advised to remove the tape after about 48 hours and let skin rest for a night before reapplying it. If the patient is sensitive due to the rigid tape, or in cases where the tape limits range of motion, it is possible to use elastic tape as well. This has been demonstrated by a research by Grant McKay looking at the effect of rigid versus elastic tape in patients with anterior knee pain. He demonstrated that the short-term effect of the tape are similar when the elastic tape is applied with 100% tension, in the same way a rigid tape is applied. After tape application, it is important to communicate with the patient about how to act while the tape is on him and when to remove the tape. While taped, move. So use taping as we did in the clinic manually. That will reinforce the MWM effect. Tape and move. Remove the tape gently and slowly if it feels any signs of skin reaction, itchiness, burning, and of course, if the area distal to the tape changes color, starts to feel pins and needles, or numbness. I always tell my patient, if you see the toes or other relevant areas turn blue or black, smelly, and the nail falls off, please don't call me, just remove the tape. Last, but as important, we should explain to the patient that the tape should be effective in eliminating his symptoms. After some time, it is normal that the tape loses its efficacy, and if symptoms come back, don't leave the tape on. Remove and reapply. Another thing to remember about taping, it is that it should be always be applied on a skin, directly on the skin. So if you tape on a hairy area, please shave and clean the skin before application. Unfortunately, MWM don't have 100% success rate. Is there any treatment that has? But fortunately, we see in the research looking at treating responders that the response rate is between 70 to 85%. It's pretty good, I believe. When unsuccessful, we should first reflect on our performance and choice of direction and force. Another aspect to reflect on is re-evaluating our clinical reasoning behind joint or spinal level selection and the level of load treated in. In some cases, it's only the need for use of a foam to reduce local tenderness that can make the whole difference. Another possible obstacle can be poor communication. Did the patient understand what he should do during the MWM? How should he react if symptoms occur? It is important to note that a response to MWM can change as demonstrated by unformed Nguyen on ankle sprain patients, and hence we should check for response on every treatment and vary our intervention accordingly. If you ask how many treatments I try before letting go of MWM, probably not more than 3 or 4. Although we are not in the miracle fixing business, I think that the immediate change brings a smile to both patient and us. So it's a good way to commence treatment. Lastly, Brian Mulligan likes quoting Louis Pasteur, saying, "Chance only favors the prepared mind." This means that when we treat, we should be focused. Every word, gesture, response may change our decision making. We can't allow missing it. So now, after completing the 3 parts of the introduction, we are ready to go. Thank you for viewing this introduction. Hopefully it stimulated you, and I'm looking forward to see you soon in the practical sessions.